Welcome, everyone. My name is Karen Lee, and I would like to welcome you to the California Improvement Network, or CIN, webinar titled Strengthening Primary Care Through Nurse-Physician Teams. Just a little information about the CIN. It was established by the California Healthcare Foundation as a social network to share ideas about improving the delivery of chronic disease care. We host these monthly webinars to share better ideas in improving the quality of care, optimizing the patient experience of care, and/or reducing the cost of care. Since we anticipate that many people will join the webinar, everyone has been muted. If you would like to ask a question during the presentation and after, please send me questions through the chat function. You can also use the raise hand function that is towards the middle right part of your screen after Dr. Sinsky has finished her presentation, and you can ask your questions directly to her. We have planned for there to be about 30 minutes of Q&A after the presentation. I am delighted to introduce our speakers today, Dr. Christine Sinsky and Ms. Deb Althaus. Dr. Sinsky is a general internist at Medical Associates Clinic and Health Plans in Dubuque, Iowa. She is a frequently invited lecturer on practice innovation, redesign, and the patient-centered medical home. Dr. Sinsky serves on the Physician Advisory Panel for the National Committee for Quality Assurance, Physician Recognition Programs, and is a director of the American Board of Internal Medicine. Deb Althaus has worked with Dr. Sinsky since 1997. In addition to being the lead nurse for the Dr. Sinsky pod with both Christine Sinsky and her husband, the other Dr. Sinsky, Ms. Althaus has developed clinic-wide protocols for home management of deep vein thrombosis and is in charge of other department-wide nursing processes. She was co-faculty for a day-long workshop at the 2010 Institute for Healthcare Improvement's Office Practice Summit. Dr. Sinsky will present on the nurse-physician team model for about 30 minutes, and then both she and Ms. Althaus will take questions during the remaining webinar time. It appears that there might be Deb will join if possible, but if she's not unable, then the nurse Maggie Tilskin, who is the nurse for the other Dr. Sinsky, will join if Ms. Althaus is not able to. Without further ado, I will turn it over to Dr. Sinsky.
Well, thank you, Karen. It's really a pleasure to speak with you today about improving office practice and primary care, taking a special focus on nurse-physician partnerships. And I look forward to our half an hour together with presentation and then our half an hour of questions to follow. And there are no disclosures. The agenda for today will be a brief introduction, and then we'll talk about 4 strategies that we've extracted from our practice that I hope will stimulate your own thinking about practice redesign, and hope that you might adapt these to your own unique environment. We'll be talking about pre-visit planning as a way to enhance the care that we give patients, a prescription renewal process that we can use to streamline our care and save some nursing time that we can redeploy to more higher value nursing activities. We'll talk about empowered teams, and we'll talk about team meetings as a way to bring this all together and make it happen. And then I really look forward to your questions, so please be bold and vigorous with your questions at the end. But to start out, I'd like to start out with the takeaway messages that I'd like to leave you with. And that is, in my experience in primary care and in the medical home, it's all about planning ahead and sharing the load. And planning ahead and sharing the load so that we can all, staff and physicians, get off the treadmill and enjoy the work. So when I first started in practice, I think I conceived of care as episodic care, and much of our care is this reactive episodic care, but we're really trying to move away from that to a model of proactive, integrated, continuous care, where the office visit is a component of that care, and we can enhance the value of that office visit by rigorous pre-visit planning. But important is all that between visit care. In our own experience, the nurse-physician partnerships, the teams between the nurse and physician have really been essential to achieving the efficiencies in care coordination that are possible in the medical home. Now, in our practice, our experience has been with nurse-physician teams, and I think nurses training is ideal for that partnership, but I realize that that's not feasible in all practice settings. And I have seen in my travels across the country working with other practices that others have been able to work very effectively with medical assistants and physicians in a team fashion. One of the things that I think it's important to think about is, and we've been working on, is building in case management, care coordination, prevention, health coaching right into this core team, right at the point of care, rather than dispersing those functions among multiple different places within the healthcare system. So I'd like to start us out with a case. And so let's look at Mrs. Peters. She's a 65-year-old who's in for her annual comprehensive care visit, and she has 3 chronic illnesses to be managed: diabetes, hypertension, depression. She also has prevention and lifestyle counseling to be done. And then she brings 3 new complaints. She's been having some heartburn, she's not been sleeping so well, and she's been fatigued. I will tell you that in my practice, she would be a fairly typical patient, and I would guess for most of the practices with which all of you are associated, this would be a fairly typical patient, certainly not the most challenging patient within the practice or the most challenging patient on the schedule for that day. But just as a measure of the amount of work to be done and a measure of the complexity of the work that we do in primary care, I want you to think about how many performance measures might be applicable to this single visit. And after you've had a chance to think that number in your head, let me share with you that according to one set of metrics, there would be 56 performance measures that would apply to this single visit. Well, the point of that is to just help us see that there's a lot to be done in the care of our patients in primary care. And I would suggest it's really too much to be done by just one person, and yet I think it's too important to be left to chance. So one of the things we've tried to do is to build the system so that the right thing happens by default for the majority of work that needs to be done, so we can focus our energies on that smaller portion that's unique and more challenging, smaller portion of the work. So for context, what I'd like to do is give you a snapshot of our practice. So Deb and I practice at Medical Associates Clinic, which is a 115-physician multi-specialty clinic. And within our primary care departments, each one of our primary care physicians is partnered with a primary nurse. So that's a stable relationship day after day, year after year. And I think that's the most critical piece of the model that has worked for us, is that stability of relationship. Then each core team of nurse and physician has a portion of a help nurse. And on average, that works out to be 1.5 nurses per physician. And as I mentioned, in our practice, we don't employ medical assistants. All of our support staff is at the nursing level. We have 3 exam rooms per physician and 1 receptionist for every 2 physicians. And a typical schedule would be 6 to 8 comprehensive care visits, 8 to 10 planned care visits, and 4 to 6 rapid access appointments. And we found that that kind of physical and personnel infrastructure supports a panel size of 1,800 to 2,000 patients. And we see our patients both inpatient and outpatient, so we cross those geographic boundaries. So key to the core team model is building this system so that the right thing does happen by default. And for this to happen, we really want a system where each one of the team members can work to the full level of their ability, with the corollary being we want to minimize the amount of time the physician spends doing work that's within the skill set of other members of the team. We want the physician to really be able to focus their energies on shared decision-making with the patient and relationship building. So first I'm going to talk to you about planned care appointments, because I think this is a place where we can enhance the quality of the care and also remove some of the unnecessary or redundant work of the practice and save that clinical energy for other activities. So in our practice, we do about 95% of our lab and x-ray before the appointment. And what this means is that when I'm with the patient, then we have current results in hand. That means that the patient can be part of the decision-making with us, working off of current lab rather than 6-month-old lab. So a typical example, a 67-year-old with diabetes is in to see us. When I'm with him in the room, we see that his A1C is within range, and we can talk about what he's doing that's working well and reinforce that. We can also talk about his LDL and how that's not at goal, and I can share with him what a recommended goal would be. I can go over with him what some of the options for management are, and together then we would very likely agree to start on a statin. Well, getting the lab ahead of time is an efficiency issue because I only need to look at the lab once, and that's when I'm in the room with the patient. And it allows for just-in-time information processing. And it allows me to close the loop of care with that patient for that episode during the appointment. We don't have a lot of loose ends hanging over. And as I visited other practices, it's been fairly consistent that for many primary care physicians, for every 4-hour clinic session, there's about 2 hours of post-appointment work to be done. And much of this is results reporting work. And we can eliminate much of that work by doing the labs ahead of time, by proactively planning for the labs that the patient would need. But it's more than an efficiency issue, it's really a safety issue, because I know I'm much less likely to overlook or miss an important piece of information when I'm looking at all the labs with the patient together. And that way the patient and the family can be part of the decision, part of the safety net. That they can say, oh, what about that low potassium that the nurse talked to me about in the rooming process? They're given the information they need to be full partners with us. So this is a copy of the lab summary that we print up for every patient, and it has the lab for today's visit, but then it also has a cumulative display of labs that they've had in the past. And the patients really like seeing how today's care compares with previous results. Well, how do we do this? How do we arrange for that lab to be done ahead of time? Well, the key concept here is that the next appointment starts today. That is, we pre-plan the next appointment at the conclusion of each visit. So instead of sending the patient away to say, come back and see me in 6 months, or call in 6 months and make an appointment, we have them leave in 6 months with the appointment for lab ahead of time as well, and that lab has already been decided. And so the tool that helps me get through my day is a very simple paper tool. We call it our post-appointment order set. It's in paper for us, although others have taken this and converted it into an electronic tool. And it's broken down into tests that are being done for acute symptom evaluation, for planned care appointments, for chronic illness, and then for their annual comprehensive care visit. But most importantly, whenever I'm orchestrating the next step in the patient's care, I can look to the top of this form and see the date of their last comprehensive care visit and the date of any pre-scheduled lab and appointments that are upcoming. And that way I can place whatever we're doing today into the context of the past and the future. So an example here would be a 64-year-old with diabetes, hypothyroidism, atrial fibrillation, renal insufficiency. And at the conclusion of her visit, I'll want to set up her next visit. So I'll look at the top and I'll say, I want her to come back in 3 months. So when she comes back in 3 months, I can see, that'll be the time she'll be due for her annual comprehensive care visit. So we'll not only set up for her INR monitoring, she'll be coming in 1 and 2 months in call with her INR, but I'll also then set up for her annual visit, and that will include the annual lab that we do for her hypertension and for her diabetes and thyroid. And with just 3 simple checks, I've gotten all that she needs ordered for her prevention and for her chronic illness care. So the concept then, this is a pretty mundane looking tool, but it actually is where I live, and it's what allows me to get through the clinic day, but it's more than that. It's what allows me to really orchestrate cohesive care, I think, for the patient. It's a plan, and it's a promise to continue our relationship with the patient. It's a way we can tell our patients, we want to see you again, and we will plan ahead to make that visit most meaningful. So that's one of the strategies that we use, and I do think that doing proactive planned care appointments with the lab ahead can save most practices about an hour of time per day. The second strategy is empowered nursing, and here I'd like to introduce you to my nurse, Deb. And I've labeled her here the boss, and I really do consider her the boss of our practice. She's a full partner with me in the care of our patient. She's really the nexus of organization that holds everything together. Between visits, Deb is an extension of me, and our patients know this. They know of our tight working relationship so that they know that speaking with her is like speaking with me. She coordinates all of our transitions from the clinic to the hospital to the nursing home to hospice. She's frequently on the phone with home care staff and family members, weaving together the care of our patients. She manages and returns almost all the phone calls of the practice and does the updating of our electronic health record and the processing of our prescriptions electronically. And she completes all the paperwork of the practice, and then she'll bring that to me once or twice a day. She'll tell me the backstory, we'll discuss it together, we'll make the decisions together, and then I can sign off on that. At the time of the visit, my nurses have standing orders to do medication reconciliation for the patient. And that's a task that I've noticed can take physicians 3 to 10 minutes per patient, but it's something that's really within the skill set of the nursing staff. And if the patient isn't certain what dose they've been taking, the nurse will call the pharmacy to find out what they've been filling. If the patient was recently discharged from the hospital, the nurse will get the discharge information from the hospital and do the best that they can so that we're starting out the appointment with an accurate list of what the patient's taking. They also do much more than escorting the patient into the room and doing med rec. They, during the rooming process, will do the initial review of the lab that's been done with the patient, so that they'll do nursing education around the labs that the patient has had. And that will allow the patient to be thinking about it, to queue up any questions they've had. And it's really changed the way I interact with our patients, because now I can go in and ask the patient, well, how's your lab looking to you? And it's not uncommon for a patient to say, I noticed my A1C is going up, and I think that's because I've stopped exercising as much. I think I need to get back to the gym. And it's changed then. It's put me out of lecture mode and into more coaching and encouragement mode. And I think that's been a change for the better. My nurses have also taken complete ownership of immunizations and colon cancer screening. During chart prep the day before, they identify which patient is due for what immunizations and who's due for colon cancer screening. And then during the rooming process, they go ahead and administer those immunizations, and they go ahead and discuss colonoscopy with the patient and schedule that for them. And we have protocols for this. If the patient declines their pneumococcal vaccine or declines colonoscopy, then I'll have a second conversation with them and often they'll then convert to accepting those. But for the vast majority of patients, that's off my to-do list. That's been built in to happen in a standardized way by default. My nurses also use their nursing judgment, and they'll do any symptom-driven tests that the patient may require, and they'll do that during the rooming process to eliminate the number of trips back and forth in and out of the room. For our diabetic patients at their annual comprehensive care visit, part of the rooming process is that the nurses do the diabetic foot exam, and they check on the diabetic eye exam and then schedule that if it's due. So again, all the standardized, predictable work of the practice, we want to have that built in so that it happens predictably and happens by default. We've also started a practice 4 or 5 years ago where the nurses will present the patients to the physician, much as a resident might present to an attending. I did this because I noticed the nurses were picking up a lot of really valuable information in the rooming process, either medical information or social information. And when they give that to me, I'm much better able to really meet the patient where they're at. And so we formalized that, and we call that our mini-huddle. And so before I go into each room, the nurse catches me. She tells me something medical about the patient and something social about the patient. And since we've done that, I've noticed that the nurses have really upped their game. They've become more engaged in the care. And it's also a time that I can mention the nurses. I might tell them something about the differential diagnosis, about that symptom, or I might ask them what do they think is going on, or what do they think we should do. And I think through month after month of that, they have become more skilled at understanding the types of problems that we encounter. And all in all, it makes for a stronger handoff. There's an example I wanted to share with you, and this was a patient who come to see us through our rapid access or same-day scheduling. And she was new to our practice, and so in the mini-huddle, Rachel said to me, well, she's here with difficulty swallowing, but she seemed depressed to me. And as I had previously encouraged Rachel to do, she went ahead and eventually asked if anyone was hurting her. The patient acknowledged that she was indeed a victim of domestic violence. And before I went into the room, Rachel had already gathered up all the information I needed for our domestic violence referral, and she was able to give me all of that information. And I was just in a much better position to care for this patient than if I just walked in cold and asked her about her difficulty swallowing. So this empowered teamwork is really central to the organizational structure of our practice. And when we have a new patient, we always introduce the patient to our primary nurse. So if the health nurses room the patient, I will bring the patient up front and say, I want you to meet Deb. She's my primary nurse. She's your main contact. She's the one I want you to call if you've got any problems, if any questions come up between appointments. And she and you will talk, and if the two of you decide that you need to be seen, she'll make sure that you can do that. She'll get you in that day. We also give our patients a welcome to our practice brochure, which introduces each of the members of the team, tells how our practice is organized, tells how they can contact us when questions arise. Well, all of that empowered nursing takes nursing time. And one other way where I think we can capture some time for more value-added nursing activity is by taking a streamlined approach to prescription management. We did a survey many years ago in our practice, and we found that the majority of calls coming into our practice were calls asking for prescription renewal. So we decided to take a systems approach to this, and we decided to renew all the maintenance medications aside from narcotics for our patients at the annual exam. And we would renew them for the maximum amount, which turns out in Iowa is for 15 months. We can do 90 days plus 4 refills. Well, that single act reduced the number of phone calls to our practice by 50%. And whether it's phone calls or faxes, that requires a lot of nursing time to respond to those requests. And I have found that it's not uncommon for a practice of 6 to 8 physicians to hire one nurse to do nothing but prescription renewals full time. And again, that's a lot of nursing skill that we can redeploy to other activities within the medical home. And so we do the synchronized bundled renewals, where every year at the annual exam we resynchronize all the prescriptions and we reauthorize those for the next year. Important thing to note is that we don't use prescriptions as a hook. That's not the way we get patients to adhere to their planned care appointments. But we use these planned care appointments. We plan them ahead. We send patients reminder phone calls and letters, and not the expired prescription as the way to orchestrate their care. And a big part of this is that it avoids loading all the interval visits with unnecessary or redundant work around prescription renewal. So how does all this happen? I want to talk to you about our fourth strategy, and that's team meetings, because that's where we really actually work through all the nitty-gritty details of our workflow. And we meet every 2 weeks, and it's our pod, so 2 physicians, 4 nurses, a receptionist, and our nurse manager. And we meet on Thursday afternoons from 1 until 2, and we meet in a room away from our practice. We have an agenda that's posted on our intranet, and anyone can add items to it. We have a pretty set template for our meetings. We have about a 10-minute check-in where everyone can go around and say what might be going on in their lives outside of our work life. So we have a stronger sense of each other. I think that's helped to build a team spirit. Then we have a time where we check back on things that we had decided upon last time and how is this going, that sort of thing. And then we spend the bulk of our time refining one element of our workflow. And then at the end, we have about a 10-minute session on some educational topic. We've talked about diabetic targets. We talked about H1N1. When the new USPSTF guidelines came out, I gave a talk about mammography and screening for breast cancer. We've had sessions where we practice motivational interviewing. And one of the important things is that not every idea that we try is going to be successful, and we know that, and we adhere to the idea that we fail fast, fail often, and learn. So I'll often come back from the meeting with lots of good ideas that I want to implement, and I came back with the idea that we would build self-management into every aspect of our clinic care. And as part of that, we would manifest that by having the patients weigh themselves when they got into the exam room. And not only that, we'd have them find their height and weight and determine their body mass index on a BMI chart. And that way they'd be more engaged in their care. Well, at the next team meeting, the nurses came back and said, that's just not working. We hate it. The patients hate it. They're embarrassed. They feel that we're asking them to do their work. So we very quickly took that frontline feedback and said, okay, that was an idea. It sounded good, but we're not going to go through with that. So it's important to recognize that not every idea is a keeper. But most of the things that we do work through actually have helped with our workflow. And so these team meetings have been this protected time for communication, for mentoring, for working out the nitty-gritty details. It's important to know that everybody's an active part of this, setting the agenda and solving the problems and giving feedback from the work that we're doing. We have made an agreement that all the changes that we implement, we'll discuss them and approve them first at our team meetings before we try to implement them. And I was famous, again, for coming back from meetings, and on Monday morning I'd have 3 great ideas and would suggest we just get started on them, and it would drive the nurses crazy because they were in the middle of trying to get the work done that we were doing for that day. And it's really much better now that we have the team meetings, and we discuss them, we think about the implications for each step along the way, we all agree on it, and then we implement it. And so that's the way we continually refine the choreography of our workday. So I'm going to end by giving you 3 patient examples that I hope show you sort of the organizational structure of our practice that has worked well for us. And Mrs. Anderson is in September for her planned care appointment, and she's come in ahead of time for her lab. So at the time of her appointment, we can together review her results. And her conditions are well controlled, so using the post-appointment order set, I can easily orchestrate her next visit, which will be in 6 months, and that'll be her planned care appointment. And that then is where we'll do the renewal of all of her prescriptions for the year. She gets a reminder phone call and letter to come in for her lab and mammogram ahead of her appointment. And in her case, the mammogram returned abnormal. And so that report goes to my nurse, Deb, and she sees it, and the radiologist has recommended a biopsy. So completely on her own, behind the scenes, she arranges for the patient to have an appointment to see one of our surgeons immediately to follow the visit with us. And in that way, when I see the patient, we can do the work of prevention. We can do all the work of chronic illness care. We can address any additional symptoms that she has. And then face-to-face, I can tell her that her mammogram was abnormal, that I recommend that we do a breast biopsy, and that if she would like, one of our surgeons can see her immediately to follow this visit. And I think that type of planning ahead and that type of teamwork between patient and physician and nurse is where we can start to achieve some of the efficiencies in care coordination that we aspire to in the medical home. Well, this is Mrs. Brock, and she comes to see us in March for her planned care appointment. She's had her lab ahead of time, but her conditions are less well controlled. So we'll make some medication adjustments, and then using the post-appointment order set up her next care appointment for June with lab ahead. And when I see her in June, we'll arrange for her to return in 3 months if needed. And then when I see her in September, I'll look ahead and see, the next appointment, that'll be our comprehensive care visit. That's where we'll link all of the annual review of chronic illnesses like the urine for microalbumin. That's where we'll do the prevention work. This then forms the underlying architecture of care. This is the foundation of care on which the rest is built. Well, she develops back pain in April, and so she calls in and speaks with Deb, and after discussing it together, they decide that she should come in that day, and so she's able to see me, her personal physician. And the key things are that she knows who to call, and she knows what to do, and she's able to be seen the same day. So she comes in, we go over things, decide that we can go with conservative management. I ask her to call Deb in a week to report in on how she's doing and anticipate that she'll be getting better and tell her that if she is as we expect, we'll touch base on that in June. Well, then in August, she develops a high fever and cough. She calls in and talks with Deb. And there are times in this scenario where Deb will ask the patient to stop for a chest x-ray prior to coming in, particularly if the patient's had recurrent episodes of pneumonia. She may have them do that before the patient sees us in the office. When I see this patient, she does have pneumonia, so I'll arrange for her to return to see me in a week. But on the post-appointment order set, I can see that she has another appointment to see me in about 6 weeks, which turns out to be great because I'll want to see a follow-up chest x-ray to make sure that that pneumonia has cleared. So I will very quickly be able to arrange for her to have a follow-up chest x-ray the same day she comes in for her lab work. And in that way, we're weaving together the management of her acute symptom care with her chronic illness care. Well, this is Mrs. Clausen, and she has all that and more. She also has atrial fibrillation. She's chronically anticoagulated. So she'll be coming in for lab-only visits at least monthly. And those results will go to my nurse, Deb. And we've tried to eliminate any unnecessary information flow and turbulence in our practice so that we have a protocol so if the INR meets criteria for stability and therapeutic range, Deb will just get back with the patient, have them continue on their same dose, and keep the next INR appointment. And she only brings to me then those values that fall outside of that protocol. Well, Mrs. Clausen is hospitalized for her first episode of heart failure in November. And every day when I come back from the hospital, I try to update Deb about how our patients are doing so that by the time they go home, she has a pretty good idea of what's happened for them. And we've instituted a hospital-to-home program where the day after they go home, Deb will call the patients and check in on how they're doing to ease that transition for the patient. She's also instrumental in helping connect them with other services if necessary, such as congestive heart failure clinic or diabetic education. She's connects with the home care staff and with the family. And again, through that partnership between the patient, the family, the nurse, and the physician, I think we can start to breathe some life into the aspirations of the medical home. So before we open it for questions, I just wanted to go back to that takeaway message that I want to leave you with, and that is that with respect to primary care and with respect to the medical home, in our experience, it's all about planning ahead and sharing the load, and planning ahead and sharing the load so that we can get off the treadmill and enjoy our patients and enjoy our work. And at that, I really look forward to some question and answer.
Thank you, Dr. Sinsky. We are now, you're welcome to send your questions through the chat function or to raise your hand for either to ask a question of either Dr. Sinsky or is Deb or Maggie on the line?
Maggie is.
Thank you, Maggie, for joining us.
So for either Dr. Sinsky or for Maggie Stilton, who is who does provides all the support that Dr. Sinsky just described in her presentation. The raised hand function is to the middle part of the middle right part of your screen. Emery?
Yeah, I wanted to find out if there was maybe just a brief description of when a patient checks in to the time that they leave the office for the visit. If you could maybe walk us through what the nurse's role is and when the physician comes in and how the visit is actually finalized. We saw the ratio of approximately 1.5 nurse per physician, and we wanted to see based on that ratio and the amount of time and the number of patients that physicians are able to see, what that typically looks like.
So I think what I'll do is I'll start that out, and then I'll turn it over to Maggie, who will describe much of the nursing function, because I think that's what you're primarily interested in. So the patient checks in with our receptionist, and they're given actually a pre-appointment questionnaire to complete in the waiting area, which asks what is the purpose of their visit, what goals do they have to work on for their health. We have a depression screen, an alcohol screen in there, and a review of systems. And the patients will be completing that in the waiting area. And we'll be notified electronically that they've arrived, and then Maggie will take it from there.
Okay. When we get notified that patients here, we grab their chart, and then, as the room opens, we bring the patient back. We weigh them. We take them into an examination room. We have them sit down. We just kind of ask them, what's going on with them. Are they having any problems or concerns? What they're here for. We've also tried to gather a little bit of social information, just kind of what's going on in their life, so that when doctor comes in, she knows if there's been a death in the family or a birth of a grandchild, something like that. Then we check their vitals, and then we go through all their medicines and make any changes on the med list, so it's updated so Dr. Sinski knows exactly what they're taking. And then if they're, there for a physical, we check to see if they're due for their tetanus, pneumovax, and then we also go through if they're over 50, if they're due for a screening colonoscopy, we talk to them about that and help them get that scheduled. And then if they're over 60, we talk about the shingles vaccination and offer that to them and give them the different options of getting that. Then if they do need like a pneumonia shot, tetanus shot, we go get those. We administer those to the patient. Then if it's a physical, we go ahead and have them get undressed. And let me think.
And Maggie, perhaps you'd like to talk about how you review the results of their labs.
Oh, yes, almost forgot. Yep, if they are there for lab results, which most of the time they are because we do our labs before the appointments, we go over the labs with them, and talk to them, and then if their blood sugar is elevated, their cholesterol is elevated, something like that, we try to give them handouts, on a low cholesterol or low sodium diet. And, we try to answer questions, and then we also review their mammogram. And then we leave those on the desk then so that when Dr. Sinski comes in, she can review those again with the patient. And that way and I know a lot of times they grab them right away because they're anxious to see what they are, and then they have time to look at them before she comes in and if they have more questions. And then we print off the encounter, and then we highlight their medications and things like that. And then we put it on the chart in the door, and then, we try to look for Dr. Sinski to give her a little report, on what's going on with the patient. And I think that's probably it. And then Dr. Chris goes in when.
And then when I'm finished, if we've made several changes, I will ask one of the nurses to print up the med list. And for patients with particular needs, the nurse will go back in and actually spend some time reviewing what those med changes are just to reinforce the plan. And depending on the patient's need, the nurse may then be the one who helps them up front with their post-appointment order set, which they give to the receptionist, which then the receptionist puts in the orders for the next step, whatever that next step might be. So that's the basic process, and of course it's a little bit different for each patient, for each patient's needs. If we start someone on an inhaler, for example, the nurses will go back in and do inhaler instruction. So as needed, we do additional instruction that way.
Great. Thank you for the comprehensive response. The next question is from Maria Madriaga.
Hi, good afternoon. This is Maria. The question is for the pharmacy management, and you did mention a one-year refill of the medication, an annual type of refill. Now, some medications require for the patient to come every 3 months. Now, what if the patient misses, what is your process if they miss the appointment and they're in this chronic medication, or a medication that requires them to be followed up every so
Sure.
often. Yeah.
And I think if I am to get at the sort of the anxiety behind that question is, well, what if we give them the enalapril for a year, but then we want to see them in 3 months and they don't show
up? Yeah.
Right, because we're so conditioned to use the prescription as a hook. But then that means that 4 times a year we have to, or more, process that prescription. And for the vast majority of our patients, when we set up the appointment, typically in 6 months, but if it was 3 or 6 months, they're compliant with that. We have a reminder phone call and a reminder letter that they get ahead of time. If a patient doesn't show, we often will know they might not be showing because they didn't come for their lab. Then Maggie or Deb will call the patient, say, oh, I see you didn't come for your lab. So that's often a way that the patient will then come in the next day for the lab and keep that appointment or reschedule it for a few days later. But if the patient just doesn't show, then the nurses have a process where they call the patient twice and then we send them a letter. If the patient chronically does not keep their planned care appointments, we have on occasion, been fairly rare, but on occasion, then let them know that we have to go in and cancel that prescription or only give it for the next month, but then we really need to see them. But it's really such a rare event in our practice.
Yeah, because it's
and I think one thing that makes sense to me is to try to build your systems for 90%. That is, rather than generating all that additional work that distracts you from doing other clinically really valuable things, build for 90% and then have a fallback, okay? This patient is chronically not showing, so I've got to take a different approach with this person.
Yeah. This is actually a very impressive process that you have. I'm just, thinking about the cracks in between,
Right. One thing that Maggie, perhaps you want to talk about, Maggie had worked for a different physician who had not yet fully implemented synchronized bundled prescriptions. And I remember, Maggie, when you first started working for Tom, you said something like, wow, I hardly have any prescription renewals. You want to talk about that?
Yeah, at the previous doctor that I worked with, we didn't fill them at their yearly physicals. We just filled them as they needed them, like when they came in and said they needed them or something. And that caused lots of phone calls for me. I just can't even count how many phone calls I had a day for prescription renewals, how many faxes I received from the pharmacy. Sometimes it was very time consuming and like being constantly on the phone was taking me away from patient care, people that were there. One day maybe somebody would call and say, oh, I need this medicine, and a week later they'd need another one, so it just makes more sense to have them all refilled all at once because it's just one time a year versus several times that you're having to go into that patient's chart, and sending a prescription.
Yeah. That's really
and I think one thing to realize, too, is that a patient, say, with hypertension will get all their prescriptions renewed at their annual exam, but then they'll come in 6 months and perhaps they'll make a medication change. That's fine. We make that medication change at the 6-month point, and they may still have some refills of that or others at their next annual exam, but we have worked with the pharmacies so that they know that when we send the new prescription, we are starting over again. We're resynchronizing these in the new prescriptions, and these prescriptions are now good for the 90 days plus 4 refills.
So you get
I see go ahead.
Oh, I'm sorry. You get a call from the pharmacy letting you know, alerting you that, we have this other prescription. Do you want to cancel it, or they just automatically cancel?
No, we send electronically. We discontinue the one medication and start the next if we've made a change. But when it comes time to the annual renewal of the medication, a patient may have 3 refills left on a particular prescription, but the pharmacist will start over again with a new 15-month window at the annual exam when we call those in.
Great.
They'll re-up them, if you will, so that they're not randomly coming due throughout the year.
Right. Yeah. That sounds like a very efficient process that you have in place. I do have a second question. I'm sorry. It's about patients that come in with multiple complaints. It's a more they come in and they're acutely ill, but then they say, I have a sore throat, but then they come in and they say, oh, you know what, my feet hurts too, and my back hurts, and my head hurts, and so forth, but it's maybe not related to the primary reason to be there. How do you handle this, the efficiency and how this patient can, be managed?
Right, because, that's an issue we all face, isn't it?
Right.
The agenda seems to get really full. And the patient, it's very, very rare for me to encounter a patient who really has a one problem visit.
Mm-hmm.
But I think that's okay. I try to take care of the whole of the patient. But one of the ways we try to address this is to know their agenda up front. So that's part of the reason we have this pre-appointment questionnaire that the patients fill out in the waiting area. And it's really a big part of the rooming process, and the responsibility of the nurse during the rooming process is to identify what is the patient's agenda, what do they want to cover. And then I am not caught off guard by that last most critical problem that is raised right when you think you're finishing up the exam, right? I mean, it still happens once in a while, but we try to make it happen less often by just planning ahead. And the other thing that I will do is I will try to have a brief sentence at the beginning. Okay, so what I see is we've got this and this and this and this. Is there anything else you were hoping that we covered today? So I try to know at the outset the scope of what we're going to try to cover. Rarely I've tried to say, wow, that's a lot for one day. Let's pick the two most important things. And still, it seems like patients aren't satisfied until they get to the bottom of the list. So that's how I approach it. I do see that one person had a question that was typed, and that was asking if we started out with MAs and moved to the nursing model. And in fact, in our particular setting, we have always had nurses as our practice partners. The majority of our nurses have gone through a 2-year community college training program, and the majority are either RNs or LPNs who've gone through that sort of training, and that's just been a really good fit for us. Very briefly, we did use one department in primary care used MAs, but it was not as successful as our nurse model.
There are several more questions. The next question is from Michael Nelson.
Thank you, and thanks for the presentation. I think it was quite nice, and sounds like a wonderful program. What I worry about is maybe almost a follow-up to the last point that you made, or last question, is really the importability of your program to other models. I missed the very beginning of the presentation as far as where this practice is located and sort of the demographics of the practice, whether there's a high managed care penetration into the practice or not, and whether the panel size was raw number or adjusted. So if those points or questions can be answered, the real point that I would like to make and ask is. It sounds like a relatively expensive program based on the fact that you do have LVNs and RNs who are managing, this, and it does seem to require a very high level of training to do what your practice has done, and whether that is affordable for, other practices.
Sure. Well, I think those are really good questions, and to answer the last question first, I think just for as a thought experiment, I think the most expensive model is when the physician is doing much of the work that other members of the team could do. And that's what I've observed in a lot of practices, is that if we don't have a nurse who's doing this, it's often either not being done or it's being done by a physician, which is very expensive. Then in terms of generalizability and context, so we're in Dubuque, Iowa, in a town of 60,000 people, and we have a mix of socioeconomic levels in our practice. We have a health plan that we own that covers 1/3 of our population. In terms of generalizability, I think no matter what your practice setting is, you can save a fair amount of staff and physician time by being very intentional about the organization and figuring out what is the organizational structure that will work for you, and getting lab ahead of time and not having all that results reporting work to do, and having a more meaningful visit with the patient. I think is critical, and that is not something that takes extra staff to do. I think doing prescription renewals in an organized fashion, renewing them at least until you plan to see them the next time, but optimally renewing them for the maximum interval for that medication, that offloads a lot of time. And if you no longer have one nurse for every 6 physicians doing just prescription work, then that's a nurse who can do some of this other work. The other thing is, if I didn't have 1.5 nurses, I would see a lot fewer patients every day. And it takes seeing 2 more patients a day to cover the cost of half of a nurse. And that's pretty conservative. So I think that when we look at the economics of it, we need to look at both the overhead as well as the incoming revenue. MGMA has data that demonstrates that there's a linear relationship between the support staff per FTE and the net revenue after operating cost. And that makes sense to me from my own experience.
Thank you.
The next question is from Elsie Nakadori.
Yes, thank you very much for a nice presentation. Part of my question has been answered. We are in San Bernardino, California, which has a very large Hispanic population, so we have a certain amount of language problems. Also, we have a clinic that has a very high number of medical assistants. And with this combination, the doctors are very reluctant to hand off various duties to the medical assistants to perform prior to the doctor walking in the room, which I feel, kind of handicaps us. I think I'm very envious of your system where you have RNs and LPNs exclusively. I wish we did.
Sure. Well, and I'm completely aware that there are different challenges in different settings, and that what has worked well for us may just be difficult to even think of building toward. We have 4 community colleges that train 2-year RNs, and I think we're very fortunate to have those 4 colleges in our area to have that level of skill available to us. And yet I think no matter what your population, trying to plan ahead and training your assistants to do what they can do. And I've been impressed with what medical assistants have been doing in inner city clinics in Manhattan, at Unite here where I've visited. And maybe you start with something, one thing, doing the immunizations before you go in the room, if MAs are allowed to do immunizations in California.
In California, they are allowed to do immunizations, but the way our clinic has it set up to streamline the whole operation, we have like a separate immunization clinic.
Mm-hmm. Mm-hmm. And so it may be something else that that you notice that your physicians are doing that may not really require 11 years of post-high school training to do that particular task. And maybe there are other pieces of the workflow that another staff person can do. And all those little things add up, because if it takes the physician 3 more minutes per patient throughout the day, that's an hour a day, right, if you're seeing 20 patients. So helping offload some of that work, I think, is really important. And I think at least in our area, our nurses are fully capable of doing all that ours are doing, and probably more.
Thank you.
Dr. Sinsky, there's another question that came through the chat function. The question is, are any components of working and communicating in different styles with people of different ethnicities and culture a part of the program?
So Iowa is very different from California in that way, in that we are quite homogeneous. And so that's just less of an urgent issue for us. We do have people who speak in different languages, but it's not a common experience for us.
Are there any other questions? You can send them via the chat function or raise your hand and I will unmute you.
And I will then answer a question that someone wrote privately, but just to carry on that last question, in your own state, I've been very impressed with the work of Tom Bodenheimer and culturally concordant health coaches, and I see that as being highly valuable. There's a question here about whether we use nurse practitioners or physicians' assistants in our practice, and if so, how. I think that, too, is a great question. I think there are many models of the medical home. In our particular pod, we don't have nurse practitioners or physicians' assistants. My experience has been that having a very robust nursing teamwork has really worked well for us. Some of our other physicians do work with nurse practitioners seeing the patients every other visit. Our nurse practitioners also make nursing home rounds, which I think has been very helpful. So that's our experience.
We have time for one more question. Is there one final question for either Dr. Sinsky or Maggie Silton? There are two questions now from the chat function. One is, have you had to work with nursing unions, and if so, how did you incentivize nursing in this process?
So good question. And we have not had nursing unions among our nursing staff. But I think the bigger question is, how do we build a collaborative environment with our nursing staff? And Maggie, maybe you'd like to speak to this, but I think that's just essential to have a collaborative working environment and have a situation where the nurses feel comfortable saying, well, what do you think about this? Or shouldn't we do that? Or do you want to remember this? Or this isn't really working very well. Can we think about doing it another way? And to me, when our nurses are participating in that way, I just think it's extraordinarily important. And we've tried to cultivate a climate where that will happen.
And then the second,
okay. Maybe we'll take the second question then, Karen.
Okay, the second question is, what is the length of each appointment, both for the nurse and the physician?
That, too, is a great question. So it really varies based on the patient. I see the schedule as somewhat of an approximation so that I don't feel that we have to have a very rigid schedule. I think when we try to be very rigid about the schedule, it makes for unhappiness for me, makes me feel very stressed. But the way we schedule is we schedule on a wave. So we schedule 2 people on the half an hour. One of those will be a follow-up, an established patient for an annual comprehensive care visit, and one will be a follow-up visit. And the nurse for an annual comprehensive care visit for a diabetic may spend 10 or 12 minutes in the room with the patient. For other patients, she may spend more like 3 to 4 minutes per patient in the room. Really just depends on their need. But for our annual comprehensive care visits, particularly for our diabetics, the nurses do shoulder a good part of the planned work, the immunizations, the colon cancer screening, the diabetic foot exam, scheduling the eye exam, going over all of the meds, going over all the labs. That's a substantial contribution that they make there.
And I don't know if Maggie, if you're available, if you are able to address the previous question about setting kind of the collaborative tone to the nurse-physician partnership.
Yeah, I think it's great what we do. When I've worked with 2 other physicians, and we never had anything like this going on, and I just think it's just better for the doctors, for us, for the patients. We work as a team here, and we all help each other out, and Deb will come up with an idea, I might come up with an idea, and the doctors are always open to suggestions, and I think it works great. Feel like we're organized here and all work well together.
Great, thank you. We are at the bottom of the hour, and I'd like to thank Dr. Sinsky and Maggie Siltgen for the great presentation and excellent question and answer session. Thank you all for joining. We will